The liver is located in the right upper quadrant. It sits directly inferior to the diaphragm. The bare area lacks peritoneum. The falciform ligament divides its lobes. The liver begins in the 4th week. It buds from the foregut endoderm. Cells become hepatocytes. By week 12, bile synthesis begins.
The liver is your body's primary metabolic factory. It filters blood, processes nutrients, and neutralizes toxins. It also produces bile to aid in digestion. Over 500 vital functions keep you alive.
The liver has 4 lobes, right, left, quadrate, but surgery relies architecture. The porta hepatis is the entry point for vessels, situated between the caudate and quadrate lobes.
The falciform ligament splits the liver into left and right lobes. It contains the ligamentum teres in its free edge. The coronary ligament secures the liver to the diaphragm. It forms the border of the bare area where the peritoneum reflects. This tension prevents displacement of the organ.
This is the ligamentum teres. It is the remnant of the embryonic umbilical vein. It is found safely tucked within the folds of the falciform ligament.
Ligamentum venosum, remnant of the ductus venosus. It extends from the ligamentum teres directly to the IVC.
Cantley's line is an imaginary plane. It runs from the gallbladder fossa to the IVC. This plane creates the true functional division, separating the right and left lobes. The Cunard system divides the liver. It creates 8 independent segments. Each has its own vascular flow. This guides precise surgical resections. The liver's functional unit is the hexagonal lobule. Here, hepatocytes are separated by sinusoids. The space of Dis facilitates transport via microvilli. Kupffer cells phagos. The portal acinus model describes the liver's metabolic zones. Proximity to the portal triad creates vital gradients. Zone 1 receives the most oxygen. Zone 3 is the least oxygenated. Welcome to Zone 1 of the liver acinus, the periportal region. Rich in oxygen, it drives glucose highly vulnerable to hepatitis and toxins requiring high oxygen. Zone 2, or the midzonal region, acts as an intermediate transition between the periportal and centrilobular zones. It exhibits variable susceptibility to injury, depending on the specific metabolic stress. Zone 3 is the centrilobular region. It has the lowest oxygen tension. Here, CYP450 drives biotransformation. This makes it highly sensitive to injury. The proper hepatic artery branches from the celiac trunk. 3 hepatic veins drain into the IVC. Portal hypertension diverts flow through the coronary veins. Hepatocytes in the liver synthesize bile, secreting it into canaliculi. It is stored in the gutter and delivered to the duodenum. In the terminal ileum, bile salts are reabsorbed. They return to the liver via the portal vein. S. typhi reaches the gallbladder. It then forms biofilms on gallstones. This state mediates chronic carriage, and it increases cancer risk.
Typhoid fever is a systemic illness. It is caused by Salmonella enterica typhi. This pathogen presents unique complications. It persists in the hepatobiliary niche.
Salmonella hepatitis is a rare but severe complication. It presents with high fever, liver enlargement, and jaundicoid nodules. Unrecognized, the mortality rate can be as high as 30%.
XDR typhoid renders standard drugs ineffective. Protocols are evolving rapidly to combat this threat. Confirmed XDR strains require carbapenems. Combination therapies are now critical. Hepatitis A is a highly contagious RNA virus. It causes acute infection with no chronic phase. Diagnosis rests on finding IgM antibodies. Prevention relies on vaccination and supportive care.
Liver diseases impair bile flow. PBC targets small intrahep bile ducts. Anti-mitochondrial antibodies are its hallmark. Ursodeoxycholic acid is the standard lifelong therapy.
PSC causes onion skin fibrosis of bile ducts. It is more common in men and strongly associated with IBD. MRCP reveals a beaded appearance. Transplantation is the only cure.
Primary liver cancer is the 3rd leading cause of cancer deaths globally. Constitutes approximately 9% of cases, arising mostly in the context of cirrhosis.
HCC is shifting to non-viral causes like MASLD. It's often detected without cirrhosis, complicating surveillance. Diagnosis relies on APOC followed by delayed phase washout.
Liver transplantation is a vital solution. A healthy donor gives a portion of their liver. Remarkably, both lobes grow back within weeks. This allows for transplant at an earlier stage.
Transplant success requires balancing drug rejection with minimization of toxicities. Tacrolimus is the cornerstone of therapy. Combine drugs to preserve renal function. Inhibitors like tacrolimus inhibit IL-2. Antimetabolites inhibit purine synthesis. Corticosteroids are potent anti-inflammatories, and mTOR inhibitors block proliferation signals.
The liver receives a dual blood supply. The portal vein supplies 75%, while hepatic arteries provide the rest. These coalesce into hepatic veins. They drain into the inferior vena cava.
Bile is secreted by the liver. It flows through canaliculi into bile ducts. These ducts merge it to form the common bile duct. Finally, bile is transported to the duodenum.
Biliary system and connective tissue is supplied by hepatic artery alone. Bile either drains directly into the duodenum or the cystic duct. The ducts enter the duodenum together, ampulla of Vater.
The liver regulates carbohydrate metabolism. It stores glucose as glycogen. It breaks it down when needed. It also creates new glucose from non-carbohydrates. The liver is the mainstay of protein metabolism. It synthesizes most plasma proteins, including vital clotting factors, and regulates platelet production.
The liver plays a key role in lipid metabolism. It performs cholesterol synthesis and produces bile. Bile is required for emulsifying fats. It also produces insulin-like growth factor.
The liver breaks down insulin, other hormones, and bilirubin, facilitating its excretion. Drug metabolism sometimes results in intoxication, but the liver converts ammonia into urea.
The liver acts as a valuable blood reservoir. Back pressure causes this expandable organ to store extra blood, occasionally holding up to 1 liter of additional blood, especially during cases of cardiac failure. Liver sinusoids are very permeable, allowing fluid and proteins to pass. This allows large quantities of lymph to form. About half of all lymph formed in the body under resting conditions arises in the liver.
Cirrhosis is a chronic condition of the liver, where healthy tissue is replaced by scar tissue. Common symptoms include fatigue, itchiness, and jaundice.
Cirrhosis stems from chronic liver damage. Key causes include heavy alcohol use and MASH, as are genetic disorders like Wilson's disease. Understanding these risks is vital for prevention.
Cirrhosis from Wilson's disease is treated by removing copper. This uses chelation therapy like penicillamine. For iron overload, agents like deferoxamine or bloodletting are used.
Liver damage from cirrhosis is generally irreversible, but treatment can stop its progression. Medications help with infections, itching, and fluid buildup. A low-salt diet is also key. Always consult your doctor.
Liver failure is the inability of the liver to perform its functions. Chronic failure results from alcohol, hepatitis, or metabolic causes. Acute on chronic failure is now recognized.
The liver is the only organ that can regenerate. Even after 90% loss, it can regrow to full size. This process replaces mass, but not the original shape.
Liver disease treatments vary by cause and damage. Some may begin with lifestyle modifications. Advanced cases may require invasive procedures. End-stage diseases may require a
Liver dialysis offers short-term support for liver failure, but long-term artificial replacement does not exist. Transplantation remains the only definitive option.